Welcome to the Recognizing and Treating Early Chronic Pain Disorder in the Injured Worker webinar. This is the 16th webinar in our Return to Work, Stay at Work series, and we're glad you're here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Direct Access Program through the BC Government. As I mentioned, my name is Tanya, and I'll be moderating the session and handling the Q&A session today. And our presenter today is Dr. Howard Hamer. Dr. Hamer is the Medical Director of the Functional and Pain Program, a program of Altum Health at the University Health Network Toronto Western Hospital site in Toronto, Canada. This is a program for injured workers with chronic pain. He is also a consultant to various industries in the Greater Toronto Area, such as the City of Toronto, Baycrest Centre for Geriatric Care, TIVA Canada, and the Canadian Blood Services with regard to all facets of occupational medicine. He is the past president of the Occupational and Environmental Medical Association of Canada and has served on the Occupational and Environmental section of the Ontario Medical Association since 2002. Thank you very much for being here, Dr. Hamer. I will hand it over to you.
Thank you, Tanya. And as we start in, I'd like to thank you for asking me to present this webinar, and also to Dr. Mark White, who is the founder of the Canadian Institute for the Relief of Pain and Disability. So thank you both for asking me to put this together. So as an introduction to the introduction, which Tanya just gave, we didn't communicate clearly on this one, but I do have the same information that Tanya put forward about me. I thought it would be important if it was not covered, as to make sure that you knew who was speaking. So I have been doing work with many different industries, particularly with University Health Network, with the work on functional pain work with injured workers. It's been most interesting doing it for about 12 years now. Actually, it's longer, and having learned a great deal that was not certainly taught to us in any type of seminars or medical school years ago. I have no conflict of interest in this particular seminar, and have had some training specifically in occupational medicine at Queen's University, at McGill University, where I took a master's degree in occupational medicine. And as mentioned, these are some of the companies I work with. Now, just a little bit about Altum Health, because I think it's important to understand where the setting is that these injured workers are found and how they are put through the course. Altum Health is a division of University Health Network, which is in Toronto, and the important thing for me is that it's a self-funding department of University Health Network. It has nothing to do with the Ministry of Health, like other places in Canada, and any work we do is outside the Canada Health Act. The benefit in my mind there is that any dollars that are created and any profit go back to the operating budget of the University Health Network, which to me seems to be an excellent way to get things done and promote our own public health system. In our program, in the Function and Pain program, there's about 150 employees, including MDs, psychologists, occupational therapists, physiotherapists, kinesiologists, cognitive behavior therapists, one of the more important groups with this population, admin and support services. We now have 7 locations in Ontario, and we are centered at the Toronto Western Hospital in downtown Toronto. Predominantly, we do specialty work for the Workplace Safety and Insurance Board, and we have 8 of those specialty programs. 7 of them have to do with parts of the body, the hip and knee, the foot clinic, etc. And the one that I help run is called the Function and Pain program. So we provide care to this very complex group of individuals, and it's a very important part of what we do is understanding the psychosocial factors that go along with this particular disorder. Altum used to be called Rehab Solutions or Rehabilitation Solutions, was established in 1989. So what are the objectives for today's seminar? I chose 3, and I'd like to be very clear that it's important at the outset to understand the difference between someone who has chronic pain and someone who has chronic pain disorder. And since I put this together just a number of weeks ago, Altum Health has begun to start to use DSM-5. So this particular disorder is no longer called chronic pain disorder. That's under the DSM-4 classification. It's now called somatic system disorder with primary pain focus or predominantly pain. Number 2 would be to recognize the early signs of chronic pain disorder because, as Tanya had mentioned to me, there will be healthcare providers listening, as well as some physicians, nurses, OTs, and other therapists. Number 3 would be the to appreciate the need for early intervention. And I think I was asked to do this talk because we did publish some research that will come up towards the end of the webinar on early return to work and the research that we did there. And what was of note is the necessity to get in early. So let's start with the concept and difference between chronic pain versus chronic pain disorder. So I decided to set it up on a left and right slide and allow you to see that chronic pain that goes on for longer than the usual healing time is the definition now that we use most often. But when you get into working with insurance companies, they want more black and white and cutoff points, and usually the literature talks, or the older literature actually talks about 6 months. What we're finding as the years go by is that chronic pain and chronic pain disorder can start to manifest, as you look retrospectively, within a few weeks of the injury itself. Now with chronic pain, an individual may be like a member of your family, perhaps a little older, who may have pain that is persistent, but their functional change is quite minimal. They don't really have to stop doing things. They may change the way they do it a bit, but there's no great change in their life. You don't really notice it unless it's a very bad day for them. But sleep is perhaps a little interrupted, but at the same time, the difficulties pass with time and they improve over a period of weeks as they acclimatize to the sorenesses that they're feeling. The chronic pain person occasionally uses analgesics, again at the peaks, but seems to cope well. And this is so you can picture a person that has pain that's persistent, but they have coping mechanisms and they probably had them long before they were injured. They're working most often, and they're able to, after the injury, increase their hours and duties. They may, as mentioned, do it a little differently, but they increase their hours. In contrast to chronic pain disorder, this is a person whose pain also persists for a while, again longer than 6 months, but the functional change very early on is quite profound. They have broken sleep, they're worried, fretful about what the pain means, they're very reluctant to move, and they fear movement, they fear re-injury, a great number of fears. The narcotic analgesic process and prescription is seen to be sometimes mishandled, but certainly quite desired by the individual who feels that that's the answer. They cope poorly and therefore look for external ways to cope. So it's medications, all sorts of different therapies, none of which seem to work. And many of them aren't working at all. They're fearful of the work, angry, and we'll get into that as the seminar proceeds. But working is very difficult, and many of them are not working for very prolonged periods of time. So again, chronic pain, simple chronic pain, the summary is persistent, often felt to be peripherally generated, so that the nervous system that's not working, in a way, I shouldn't say that, I should say more that it's working appropriately, and when someone bangs it or they walk a little too much, that damaged tissue will tell you that there's something going on there or was, and it's sore. This kind of pain responds to heat and ice with a lessening of the sensation. It actually helps. They feel a little better. And in fact, they can go on and do more after they have, for a very short time, 20 minutes, half hour, decreased the pain with their external modality. Their lifestyles, it's not interrupted to any great extent. And this may happen after a simple or devastating accident. It may have to happen after a surgery as well. People have persistent pain that's a nuisance. Contrasted, again, as mentioned, to the chronic pain disorder, and again, I write this down as the somatic system disorder because you're going to start to hear that over the next year rather than chronic pain disorder. So I'm very used to, over many years, using the CPD acronym, but I think that's not long for this world. So we have an overwhelming change. This is not a peripheral disturbance. The models and the theory and the science now is starting to unveil to us where the problem is. And it seems to be a sensory disturbance of the pain system that is central. That is either central in the spinal cord and the dorsal horn, or in the cortex and dorsal horn as a mixture and a communicating pattern. This pain, when you get into chronic pain disorder, seems to be triggered by normal touch and normal movement. In contrast to the chronic pain, plain chronic pain, that is giving people problems because they kind of overdone it. They've walked too far, or they've shoveled too much, and that old shoulder injury is now kicking up again. The chronic pain disorder people have very minimal touch and movement disturbances that will trigger their pain, and often they'll get a 10 out of 10 pain from just moving their arm from side to side. Very important is the last point on this slide, is that the pain that they're describing does not indicate continuing tissue damage. And that's what many of the individuals are told. Well, you didn't heal, you're still healing, and this is 8, 10 months, 2 years later. They're not healing. There's a deficiency. They have an impairment of their sensory pain system. So following the process of this pain holding on and their fear being present, they develop behaviors as a population that are sometimes quite bizarre, but lead many of the lay public to think that they're faking it because it's so over the top. Their explanation about what's wrong with them is they can't walk, they can't lift, they can't carry, and as they say that, they have just walked into the room or they've just lifted their purse. So it's that overdoing it, that catastrophic thinking that everything is terrible, nothing's going to ever be better, and they fear very much the movement of the limb or the sitting position for their back, that they will be damaging themselves. They fear greatly that they will become quite invalid. Some are very angry, and many withdraw because no one believes them. And this is something in the program that we provide is very much important for us to allow them to understand that we know they have pain, but the pain they have is a disturbance of the nervous system, and it's a benign problem, however terribly difficult for people to continue to cope. Not uncommonly, by about the 6th month, people become depressed, and even though we have not found this in our research at the end of the seminar to be a statistically significant problem, depression is extremely common, and without treating the depression with the chronic pain disorder, it's very difficult for the individuals to concentrate or to move forward. So you must also add into the mix that consideration of depression. And unfortunately, many of the individuals, because they have poor positive coping skills, they have many negative coping skills. And these negative coping skills, everyone copes, but sometimes people cope in a negative way. They tend to want to dampen down the pain message by trying to use street drugs, alcohol, and this tends to exacerbate the pain, really. Often the pain centrally seems to keep moving upwards as opposed to being controlled. The alcohol often is a depressant and feeds into the above point of depression, causing increase of depression. And then the poor sleep. Poor sleep is a hallmark of chronic pain disorder. Broken sleep, sleep that's scattered and unable to be refreshing. Depression aggravates the sleep, and poor sleep aggravates the depression. Individuals, therefore, look for any way to get a better sleep pattern, and often they'll use more and more of the narcotic, which again gives them a poor sleep architecture and doesn't allow them for restful and restorative sleep. And this population tends, unfortunately, to externalize the problem tremendously. It's the employer's fault, it's the physio that didn't do the right job, it's the surgeon that misdiagnosed them, and it goes on and on. We know, in general terms, that when people improve in this particular population, they start to understand that they're the only ones that can handle the pain, and they're the only ones that can decrease their pain experience. So when I talk about a pain experience, those words come from theories that are actually quite old. I was interested to see that Dr. Melzack, who originates also from McGill, was doing this kind of work in the early to mid-60s. The first theory that he and his co-workers came up with was called the gate theory. And this, as I describe it now, what is interesting is that it's so common now to understand the interplay and accept the interplay of a nervous system talking to one nerve talking to the other one, that it's hard to believe that it was so simple and simplistic a theory back in the early 60s. So this is the gate theory that he started with. He and Dr. Wall, psychologist, had small and large fibers in mind. Small fibers being, in their mind, the pain fibers, and the large fibers being the touch fibers. And when a person was touched by the large fiber, there would be inhibition or no interconnection with the small pain fiber, and the person would feel the feeling of touch. So the gate was closed to the pain system, and all that was felt was touch. However, if something were a painful experience, then the gate was open to pain, and the theory was that the message got through as the pain system allowed for the inhibition of the large fiber. As this model became more accepted in the 60s, it seemed to make sense when your kid would trip and fall and bump their knee that you'd get them to rub it, and this would decrease the pain sensation. And it fits nicely into this whole idea of one neuron talking to the other neuron, and that way limiting, inhibiting the sensation of pain. But very closely after that, this was the gate theory of 62, and the neuromatrix Dr. Melzack came up with more around 1968. So very close proximity, he was able to realize that that simplistic view was not enough to explain all the things that we see differently in a person that's suffering with prolonged and chronic pain. What he was able to put forward was the idea that an injury can be experienced in kind of two ways. So you have the right side of the diagram and the left side of this diagram. And on the right side, a person's injured and moves in, and they don't have fear. They experience the pain, but they don't have fear of the pain. They understand they're probably going to get better. They understand the treatment. And they move from confrontation of the pain and the idea that they may not be perfect anymore, the whole thing may change and slightly shift, but they recover, and the pain tends to settle. In general, pain tends to settle within, it could be as short as a few minutes, but usually within 3 weeks, pain has really dissipated, and you may be left with a dullness that lingers for another 2 to 4 weeks, and by 3 months, the pain should have disappeared completely. Again, in contrast to that, you have the individual who has the painful experience based on surgery or an injury and becomes to worry about this, what's going on. They're very worried that it's not being controlled adequately, and they become fearful, and they start worrying that the worst is going to happen. They'll never walk again. They'll never be able to use their arm again. They better protect that limb and stop it from moving so that it will get better. So that's the avoidance piece, and that's the farthest away from what they should be doing, because as soon as they do that, there's a whole cascade of biochemistry that occurs that leads the individual into big trouble with disuse, problems with the limb, sometimes reflex sympathetic dystrophy, but certainly they lose their confidence, they lose their ability, and they become depressed. So what Dr. Melzack put forward was this concept of a neuromatrix, that there's more going on to the pain experience than just that idea of the electrical wire goes from your burnt finger up to your brain and then back to pull the hand away from the hot element on the stove, for example. So what he, with his co-worker Cates, Dr. Cates, they conceptualized 3 main areas that influence our ability and perception of pain, and that's the cognitive piece, the sensory signaling piece, which was the simplistic part of the gate theory, and then the emotional piece. What that led into was a matrix of neurons in the brain and in the central central spinal cord that left off to and led to pain perceptions. The person realized that they were in pain. They also had things they did or didn't do from an action perspective. In other words, moving the finger away from the hot stove would be an acute response. But working, not working, walking, not walking, those are the action programs. And if the person were on the right side of the former diagram and they settled down nicely, their stress hormones would not flare, only for a short time, allowing for the whole immune system, the inflammatory system, to allow for healing to begin. So this is an illustration of what happens when the system is working pretty well. The pain drops down on the right side of the diagram, and the person is doing what they're supposed to be doing. The input is pretty much on the left side of this diagram, even. So the person may remember that they were properly advised prior to treatment after their injury. They understand that they broke their leg or they tore some ligaments in their ankle. They understand that, and they understand it's going to be sore, and they're given good explanation. They have no memory that's negative in their past. They're not worried about financial things. They're not worried about all sorts of things that are coming into other person's presence, and therefore the signaling system seems to be appropriate. Everything's balancing. And the homeostasis allows for their stress hormones to react in a way that's healthy and it doesn't overdo it. However, if someone has significant good memory, then this may lead, again, to a resolution and decrease of stress. But if you look at it on the opposite side, that their brother or sister had a similar injury, they were laid up for months and months, they became addicted to narcotics, they had extreme problems with their workplace. This may be the cognitive piece that frightens them and allows for increased stress hormones, increased pain perception, and a lack of action. So this is where in the center of this diagram, where Melzack puts a magnifying glass. And sometimes that magnifying glass can be very powerfully positive. For example, when people learn how to do natural childbirth and allow for their pain system to be controlled nicely by explanation and technique. But it can also be a magnifier for the negatives, as just in the last example. And manual therapy tends to help that, tends to help settle things down, tends to go back to that gate theory and put through some of the touch fibers to decrease the pain. But when you're overwhelmed with the cognitive problems and the emotion of fear, then the whole right side of the diagram flips over and we get into significant pain perception, significant stress hormones out there. The immune system starts to adjust differently and sometimes even breaks down in the most severe cases. And this is called the neuromatrix. Also in his work, he talked about the neurosignature by telling us that likely everyone has their own way that transmits information through this neuromatrix. And that signature is partially genetic, partially experiential. And that means that's your neurosignature. That's what the one person who's sitting in front of you has their way of thinking through these problems and either magnifying them positively or negatively. So what happens really when the person walks in? What's clinically going on in the real world as opposed to the theoretical world? What we found very useful in the past decade or more at Altum Health has to do with the yellow flags that were first put forward by, I think, a number of individuals, but the one that we use the most is the one from the New Zealand group. And there will be at the end of the seminar in the references, a reference to their website. Very, very useful. If you haven't gone through the New Zealand, it actually was developed for chronic back pain because that's the most common affliction that we see in injured workers, and therefore the largest number and therefore easier to study, and the research goes on with low back pain. But the yellow flags are important. The yellow flags indicate psychosocial problems. In other words, things that people are thinking about and things that people are surrounded with in their day-to-day lives. And the ones listed here, I think there's about 9 of them. They're by no means the entire list of all the psychosocial factors. These are the ones I've chosen that I like the most, and we will go one at a time through them on other slides, but let me just go through them briefly here. It is a belief in the population that we see with chronic pain disorder that the pain and activity, it's very harmful. If they have pain, they should not be active. They should be sedentary. They also see themselves as having an illness or a sickness behavior, and they feel comfortable at the extended rest and calming everything down, not rocking the boat. Excuse me. Their mood is often low, as another yellow flag that you should be looking for, as mentioned about the depression, and often withdrawing from friends and family. Sometimes the treatment that is provided for them is not the best treatment and links up to the two above, that they are told to rest. If it hurts, don't do it. Lie down and wait, and the pain will slowly go away, which can happen, but this particular population will be fearful of that, and everything tightens and fibers shorten in the muscles and the pain escalates. Problems with claim and compensation, so this is the social part of the problem for chronic pain disorder, is that people often are in a compensation model, and to continue to get paid have to continue to have pain. And it's not a conscious thought, but it's how can they go back to work with so much pain? They must continue to stay on that until someone cures them. The next one has to do with history of back pain. So this is another tip-off or a yellow flag that someone has been off for a long time with back pain. Often it's 3-4 months to years, 2 or 3 times prior to the time you may bump into them. So it's important to flag. Also, they are not happy with their work. They have difficulty at work. They'll relate to you, and often the work is heavier. It's rare that we see it not in the heavy work setting. The lighter work does certainly have chronic pain disorder, but it's easier to get them back to work. And unsociable hours, we have the shifting often comes into play here with the heavy work. So they're doing a rotating shift process. They're working in the middle of the night at very heavy work. Family support, again, gets back to the social piece. And either they're too helpful or not helpful enough. So as I want to go through these yellow flags, again, to emphasize the importance of recognizing where you are, because once you recognize what their fear is and where they're stuck, you then can institute the treatment, particularly the cognitive therapist can, and we do this in teams, this work, so we allow each other to understand what we've picked up in different meetings with the client and patient. So the belief that the pain is harmful leads to excessive rest, as mentioned, and sedentary lifestyle. But what you have to remember is muscles are built to move. They're not built to be stationary. And if they're stationary, the toxic products that we metabolize into every day, into our muscles, linger and cause irritation in the muscle fibers and sometimes spasm, but the fibers shorten. And then when you try to do something, it's extremely stiff and painful, as everyone knows who's listening. If you've been doing something very strenuous the day before, you're going to be sore the next day. What this is interpreted by the individuals with chronic pain, or misinterpreted as further problems, and they're getting worse, and therefore they limit further. And then in the worst case scenario, you're going to get people that have overdrive in their parasympathetic sympathetic nervous system, and they wind up with this reflex sympathetic dystrophy, which is very difficult to treat and extremely painful and unpleasant. Also, it seems that there's a reset in the dorsal horn of the spinal cord, allowing for allodynia. Allodynia is a feeling that normally causes touch sensation, but then stimulates the pain fiber this time. So again, there's a mix-up of the nerves and the communication in the central system. A normal touch will cause pain. Hyperesthesia is a very light touch or a very mild scratch will cause huge amount of reaction to a painful stimulus, but it's a mild painful stimulus that has to be done. So that's one of the yellow flags to be aware of. This whole illness behavior, the way people take on the sick role, and catastrophizing is a very important thing. There are questionnaires looking only at catastrophizing responses, and if you're getting into the high levels of catastrophizing in your responses, then you will find that you're most likely having a person with chronic pain disorder. Catastrophizing, as mentioned, having to do with looking at the worst case scenario of everything going on. You'll never get back to work. I can't lift and carry. I'm not able to be married anymore. I can't lift my children. Therefore, I'm a terrible parent. So these are the catastrophic thinking that leads people to become depressed and become less and less functional. They need excessive help, and in the upper extremity, very difficult for them to lift and carry. They don't do their own personal hygiene, and it gets into a very dependent situation. Lower limb, they start using all sorts of walking aids and canes. I remember one woman came in pushing her wheelchair, which had a walker collapsed on the wheelchair with 2 canes hooked to the sides of the wheelchair. So she was ready for anything, and very much having that, see how terrible I am doing. In fact, she has certainly had pain, and we were able to calm a lot of that behavior down with her understanding of what was really going on in her system. Most people stop engaging in exercise, which, as we're learning more and more about exercise, we see that that's a real problem, not only for the strength of the muscles and the stretchability of the muscles, but also it has a very positive impact on our mood. And we need exercise on a regular basis to keep our mood elevated and normal. And when you ask them, as we all do in this field, give me a reading, visual analog score, it's called, of your pain out of 10, with 0 being no pain and 10 being the most, often they'll say that they're having a 12 out of 10 today, or a 20. So that, again, that's the exaggeration of the individual. Back to the low mood, very, very important, commonly associated with depression, and persons that come into this problem with depression do very poorly. So if they're at a pre-morbid or the pre-injury state is that one of a depression that has not been well treated, then the injury itself can exacerbate this to quite a level of a depth of depression. They can be irritable and not necessarily low in mood. They just can be angry and irritable and not easily talked to. They're anxious, very much focused on their body, and they feel very much out of control. And I think that's a very key point to a lot of individuals who don't know what to do. They feel useless. They feel set aside by their workplace. Often their complaint is that no one has called, and just to see how they're doing. Antidepressants are very useful, and what we do is we get people to start onto antidepressants most commonly, and this allows them to get to a point where they're kind of feeling more like themselves. They're certainly not out of the woods, but they're more like themselves. They're able to listen, concentrate, maybe read a few things. Prior to that, it's pretty much useless to speak to an individual who is so depressed they're not listening. They're very much into themselves and down. So treatment that does not fit the best practice, we may be having individuals go for months and months and months with trigger point injections. And these, certainly in our center, injections are done by the group of anesthetists, but if they aren't helping in any way at all over a period of 2 to 3 injections, they're stopped. Trigger point injections do nothing for the individual in the long run unless they're used together in conjunction with therapy, both therapy of cognitive therapy and understanding how their thinking is making them continue on in the chronic nature of their pain, but also in the physical and physiotherapy of the problem. So trigger point injections are not bad if they're used in conjunction with other methods of increasing function and activating people. People tend to walk less, rest too much, and then slide into this whole problem of high-dose narcotics. What we found is that, and it's confirmed with the literature, is that we convert everything, all narcotic medications that are used by our population into morphine equivalency. And the guidelines, the Canadian guidelines, certainly tell us that a greater than 200 milligrams per day of morphine equivalency has no great use to control chronic non-cancer pain. In other words, all you're going to get when you get into the 400 milligram a day and 1,000 milligram a day is more side effects and an increased possibility of serious side effects and death. There is a dose response curve that they show us, of as the morphine equivalency rises, the risk of death rises in a parallel fashion. So the person, again, expects the problem to be fixed. They have no, they're not involved in the treatment to any great extent. And they often stop movement, which is a very bad idea. And back to the compensation piece, we see mainly people from WSIB and some from motor vehicle accidents, small numbers, that are also very entitlement focused. We can often build them up with when we're having them return to work with perhaps a workplace therapist, but they get to about 6 hours and then they become fearful again that they're getting better too fast and able to function better, and therefore they commonly stop at 6 hours a day and are unable to work a full 8-hour day. Their anger is displaced onto insurances and employers. They blame the employer, often for safety issues. Some of the individuals are better off at home financially, which becomes very difficult to work through the problem. And again, as mentioned, they often talk about poor claims management, and we get a report, sometimes from WSIB, that they've been off extended periods of time in the past. And as is no surprise, many of the individuals were not happy at work to start with. They had interpersonal problems, the productivity was poor, sometimes they even had a performance appraisal just prior to their injury that was not up to the level that was expected. Attendance may have been a problem. That's another yellow flag or part of the yellow flag process. And that they're working sometimes on shift work, a rotating shift. Being on a standard, same time of day, every day timetable is different than rotating shift. And the rotating shift piece is very difficult for individuals, sometimes prior to the injury, but often after the injury, to get back to that type of lifestyle. It's very difficult. The family can be too helpful or not helpful enough or not even in existence, so that the spouse, certainly in some of our South Asian communities, the spouses do too much, particularly if it's a male injured worker. So if the spouse, therefore may be female, would be there to help and does everything for the individual. Unfortunately, this is the worst thing that can happen to an individual trying to activate. The spouse's anger because the worker is no longer in a full-paying job and only getting compensation for 85% of their pay may become quite angry and may fuel a negative attitude towards the workplace, and the whole thing tends to inflame. Then again, if someone has no family at home, they become much more isolated and often more depressed. So having gone through those yellow flags with you, the ones that we find the most helpful, we now have to understand them and then move into a treatment pattern that helps these individuals. The most important thing, as mentioned right at the beginning of the seminar, was that getting at these individuals, first recognizing them, and then getting at them at the very early stages is the most important thing you can remember. So the longer it goes, the much more it becomes very complex, the treatment, to get these people better. And getting better has a whole different sense depending on where you are in the spectrum of individuals. Some have some coping mechanisms that they use, some don't. Getting better means functioning better. It doesn't mean getting rid of the pain usually. Often the pain is set into that whole neuromatrix idea and doesn't seem to vary a great deal. But as you get them better functionally, their pain levels tend to drift down from 8s and 9s to 7s and 6s, and sometimes even to 3 and 4s. So acutely, and in the subacute, when you first see them, if you're lucky enough to see them very early on as a therapist or a family physician, then you must be very positive. Often the injuries are very low-level force. There are slips and falls, there are twists, there are trips. I saw one guy who banged his head on a fire extinguisher that was on the wall above him and hadn't been at work for 3 years. The imaging is usually negative. Excuse me. And when it is so, and you get that history of low force, low level problem, then you may be able to get a sense that you're starting towards a chronic pain disorder scenario. And it's most important to be positive and allow them to understand that, sure, you understand that it hurts, but to do things is the way you get through this, and don't worry about the pain. It's something that is there, and it's supposed to be there because you injured yourself, and therefore keep going, and it will slowly settle down. You also have to ask about those yellow flags so you know what to expect. This is the time when you first meet them. And if they're having difficulty at work, acknowledge the difficulty, and then ask about employee assistance programs or counseling that they may need to try to get them over that hump so that they don't slide into the chronic pain disorder because of their difficulties at work. The person that comes in and says to you, well, you've asked the question, you're at physiotherapy now 2 weeks, how's it going? They say to you, I'm getting worse. When they're getting worse after physiotherapy has been going for 2 to 4 weeks, it's a very important sign. The pain is increasing. They don't listen to me. I'm not getting anything out of it. Those kinds of statements are very important to start worrying a bit about the individual who may be going towards a chronic pain disorder. So you have to therefore explain to them that they're going for their management and their therapy and rehabilitation to teach them how to do it themselves. No one's going to make them better. They have to rehabilitate on a regular basis at home. So these exercises and stretching is not just for when they're in the physiotherapy department. And we all know this, and most of us experience this, but you'd be surprised that they're so fearful that they go get fixed at the physiotherapist and they go home and do very little. Again, the emotional distress, they're worried, they're anxious, they're angry. These kinds of emotions are not good for recovery. Very often now I'm faced with the question from management as to whether people should be working from home. Working from home in general terms is a bad idea. You isolate the individual. They don't, when we're out and about, we have to get dressed, we have to put, comb our hair, put on a nice piece of clothing. It's something that we have to do to present ourselves to the world. It makes us feel better. When you're at home and you're not trying, your mood will drop. You tend to focus more on yourself. You tend not to be out there when someone says, how's it going? You say, pretty good, as opposed to, I'm doing terrible. Because when the spouse comes home and you've been home all day and that pain is just gnawing at you, that's when you really focus on it with the spouse. And you don't need that. You need them out in the workplace as soon as possible and as early as possible. Hopefully the workplace has perhaps some modified duties that they can get involved in. And if they were active people, this is often a big crash for them, that they were active and now they can't do anything because it hurts. So you encourage them to get out no matter what and do what they're supposed to be doing is movement, but perhaps in a different milieu of exercise. So if they're big joggers or they love biking, then maybe swimming would be better, or cycling calmer for them and not going up all these hills, more flat. They have to keep moving. And finally, you have to tell them that their request to stay off work is unhealthy. It's healthy to be at work psychologically and movement. Also to allow them to re-engage with people and to show their management that they're trying. Modification of jobs is very important and sometimes works well, but if you're the therapist that's giving that modification recommendation, put a time frame on it. Make it reasonable. They should start by doing less lifting for 2 weeks, and then you reassess. But it should always have a time frame on it, because in this population particularly, they will stick with what you start with. Sometimes a different job is necessary. It really depends on where they're coming from. And job coaching, and we'll get to that in the research, is extremely important and helpful. No great shakes to stay at home. It's not a good place to be. Now, if you're getting into the chronic picture and people are starting to be out of work a long time, and you as the perhaps primary therapist, primary practitioner, family doctor may say, gee, I didn't even realize it's been 6 months already, because certainly in my practice 6 months goes by very quickly, and you might have seen the person twice initially and just maybe at 3 months, but the 6 months tears by very quickly. Or you've inherited them or picked them up from the emergency department after many, many months or years of treatment, and they've just got fed up with their own doctor or vice versa. So you may have a person that is into chronic pain already when you first see them. So you must set up a management strategy, a management plan early on, telling them that they have to keep moving and give them all the reasons why they must get back to work now, not when they feel that the pain is gone. If you don't put that first visit, if they're a new patient, clearly in front of them, you drop the ball. You can't really go backwards and make rules later on. It's very important because many of these individuals are shopping around for therapists and doctors who will understand them from their perspective, but not encourage them to increase their function. High opioids, as mentioned, are not indicated. Tapering is needed. That wasn't mentioned before, that when you foresee them, if you're a physician, you must start them on a tapering dose. Get them down, no matter what they start at, 10% every week to month, depending on how you're able to do it. But you bring them down slowly, and you just put it on paper and follow it. And they have to sign their contract as put out by our guidelines that have to do with opioid management. Stabilizing the mood is mentioned, and sleep, very important. Sometimes you need non-addicting, non-sedating for the next day pharmaceuticals, and that's often the tricyclic antidepressants that help a great deal in that regard. And cognitive therapy is an extremely useful tool and been found to be very important, particularly in team approach, as in the team that we use at Altum Health. So what is that team? That team is called the Function and Pain Program, as mentioned, and it's an interdisciplinary team program that lasts about 30 sessions. So it's 5 days a week for 6 weeks, and each week that team gets together and does what's called rounds, and they go through all the clients or patients under their care, and everyone discusses what they've been observing and what's been accomplished through the week. This discussion will often happen in the hallway as well, but there's a set time to have rounds. So because these individuals often are looking for reasons that they shouldn't do things. They're very good at failing their treatment, not good at accomplishing things. And if we can, as a group, sit down and put that on the table and understand where they're at, it's very important. We get feedback from the cognitive therapist as to where they're at, as well as the psychologist as to, in general, how to deal sometimes with very difficult personality types. The cognitive reframing is done by really everyone on the team, led by the cognitive behavior therapist. So he or she is telling us every week what they have worked on, and therefore we can pick up on it and add it to the time in the gym or the time when they're walking or even when they're listening and talking about their own medication use. Over many years, we have seen hundreds and hundreds of individuals with chronic pain disorder. And the chronic pain disorder is a spectrum. It can be all the way from plain chronic pain to someone who sees themselves as totally disabled and unable to move out of their house. So there is a spectrum of this disorder, and the treatment, therefore, will hinge on what their abilities are and move them forward to more ability. So in the research, we decided to try to figure out how we can see people and predict what kinds of things will help them when they're really out a long time out of work. I worked with Dr. Gandhi, who is an epidemiologist and orthopedic surgeon, Sandra Wong, who worked well in coordinating the program, Emily Yak, who was our research assistant, and Dr. Mohammed, who is the overall director of the Function and Pain and Altum in general. So, like any research, we had our preamble and opening part of the research, talking about, in general terms, Ontario with its lost time injuries overall. That's not pain, that's all the injuries in a certain year in Ontario with WSIB, the Workplace Safety Insurance Board. So about 64, just shy of 65,000 claims. And how we explain to the reader about the psychological, behavioral, and physiological mechanisms that exist. So it's a psychosocial model that we were putting forward. And that leads into this slide, which delineates the bio part, the biological part, the psychological part, and the social things that knit together and are all reflected in those yellow flags as mentioned earlier. So that the basic premise of getting people back to work is it improves their quality of life. It gives them a better self-image. Their confidence rises considerably if they're been out and they're starting to succeed at returning to work. So what we wanted to do is have our primary objective to understand the factors that might predict return to work 3 months after they finished the 30-day program. So after 6 weeks, they returned 3 months later. And at that time, we were looking to see what factors had succeeded in getting them back to work and keeping them at work. Our study occurred January 2009 to March 2011. In that, our sample was 1,000 or so injured workers. A little more of male than female, and the mean age was around 46, which over the years hasn't varied that much, but snuck up. It used to be 42, 43, and now it's up around 45, 46, which probably, reflects the aging demographics that are seen in Canada. So as mentioned, the treatment program is 30 sessions. So our demographic data was time from injury we were looking at, any comorbidities, the work sector they're in, and the statistician were using logistic regression to try to understand these factors. So what did we find? We found that the return to work rates were very much better the closer you were to injury, which was no great surprise. It's more logical. But we found it was 21%. Overall, that if you take that whole graph, it's about 14%. But when we stratified it, we found that it was 21%. So these are the factors that we were looking at, and the ones that are highlighted are statistically significant factors. And gender, we felt, probably was twice as likely that a person will get back to work. Female, likely because their jobs could be modified. Born in Canada may indicate a surrogate for language. A lot of what we do in the program has to do with explanation and lecturing and talking back and forth and interchange, and therefore the language factor, although we always had interpreters, the nuances may have been lost to some degree. Time since injury, very important, but not as strong an odds ratio. But the one I want you to go away with is what's called a return to work coordination service. That had to do with when we were sending therapists into the workplace with the individuals, regardless of how long it was. It was a almost 3.5 odds ratio, or more likelihood, 3.5 times more likely that they would get back to work with someone at their workplace helping them out. So the key findings, 14% overall, 21% if it's earlier, 15 months or less, and then the key predictors. And our recommendations were that the workers' compensation boards across the country should be getting at this problem much earlier. I've been taking a lot of effort in trying to get our workers' compensation board to understand this, and they certainly understand it, but to implement it is very difficult. And using an interdisciplinary approach seems to be the best as far as literature tells us, and it seems to have worked with our population as well. So in summary, chronic pain disorder is a sensory dysfunction. If you're into the disorder, you're going to have behavioral changes that come along that you must be aware of and recognize and get at it early. Understand the fear of the worker and deal with it, and get that therapist on site if you can. Many workplaces have therapists on site that will work with the person, coach them through, and allow them to start decreasing their fears and allow them to increase their functionality at work. Using the New Zealand flags is very helpful, and the guideline follows. As mentioned, it's developed for back pain. Here are the references, our own research paper, Altum Health's website. I use a lot of Dr. Patrick Wazell's work, very much into the psychosocial aspect of return to work, and then the New Zealand back assessment. So I thank you for your attention, and I listen for now Tanya's emails or questions that may have come through.
Great. Thank you very much, Dr. Hamer. I did have one question that came on early in the session asking for a little clarification. Someone thought that it was somatic symptom disorder, not system disorder, and just could you clarify that?
I have written down somatic system disorder. What did they think it was?
Somatic symptom?
Could be. I haven't started to use that yet. Yes, I have it on my bulletin board in front of me here. Somatic symptom disorder. That is correct. They are right. It's not system.
Very good. And then someone else asked, in conjunction with one-on-one education, are there any resources, references that you provide your clients with that you find helpful?
Unfortunately, the population that we see is very far along, and the one-on-one is not all that useful by the time we see them at the average of 3 years post-injury. We're starting to see them much earlier on and starting to develop a process whereby we can give people that are much lighter in the problem information. But what I'd like you to do, Tanya, is send me that, and I will respond to that particular individual with any resource that I can have. I'd have to speak to the team on that.
Okay, that'd be great. And actually, I might, any resources that you do end up finding, I might be able to post on our website just for people to access as well.
Absolutely.
Great. And then someone else asked, what if the person is unemployed?
That's the hardest thing, and that's why the whole point is to get them early. Now, if they start unemployed, then they're not going to come through the workers' comp system. And they may come through with the motor vehicle insurance process. But in general terms, all of them were employed when they're injured, probably greater than 90% of our population. If they're unemployed, it's very difficult, and you're trying to get them just to increase their quality of life and their ability to do more functioning around the home. So we don't do vocational counseling at that point in our program. But once their function improves to a point where they think they can do more, then they have to move into the community and deal with any vocational rehab that might be available through social services.
Great. And then if you find that a patient has plateaued, how do you disengage, or what's the endpoint navigating that balance?
Plateauing that we've noticed is often due to motivation, and we do have some training that goes on with the psychologist with regard to motivation and trying to move the person from there. But what we found is there's always reasons for things that slow down and stop. It's either the pain, most often, but often a fear of something. And that fear of something can be, sometimes, unearthed by the cognitive therapist or the psychologist, and that sometimes moves them over that plateau or that little hump, and you carry on. But the plateaus and the breaks that these individuals put on the process are quite remarkable, and it never ceases to amaze us what people come up with why they can't do things.
All right. And someone asking, what about when you have someone where there's the pain and the depression or another mental health illness involved? Is there a tactic of, do you tackle one first or another, or is it an at the same approach, like at the same time approach?
You're always trying to activate individuals to be more, to use exercise more. So even if it's simply walking, it's important as you lift the depression, often with medication. Most of the people are quite profoundly depressed that we see when their depression is a diagnosis in their chart, and therefore we usually move towards medications because it's the quickest way to get them elevated over a period of 2 to 4 weeks. So that a lot of what we do has to be contingent on that. If there's other comorbid problems like addiction, we tend not to work with addiction in our program, but we did, over a period of years, create an affiliate program for addiction that we could bounce the people back and forth so we didn't lose contact with them. That was successful, I thought, for a short while, and then was stopped. The funding was pulled from the funding insurance agency. So it's always an ongoing process of how to deal with these very complex individual problems. But sometimes we'll have to send them to another teaching hospital if, for example, they have addiction, and allow that to settle first and controlled. Interestingly, one of our therapists and doctors was an addictionist, a person that worked with addiction, and found that the treatment and the activation that we use for chronic pain was much the same as individuals that have addiction. So it was interesting that the cognitive approach was the same.
And then someone asking, as an employer, how do you best approach a situation when extended time away from work is the continued medical recommendation, even though job modification may be available to support their return to work?
It really depends on the situation. If, for example, I'm being asked that as the occupational physician and consultant. With a nurse, often the nurse will be sending a question out to the individual physician, usually, or sometimes physiotherapist, as to what are the medical problems that are ongoing. If it's just pain, then sometimes we have to have a conversation about how the individual may be actually exacerbating the painful process and the pain syndrome rather than alleviating it to some degree. So sometimes there is some education that's needed on the employer's part by asking consultants to call the individual physician.
All right, and then what can be done when employees are seeking secondary gains from a third party and they feel it will be detrimental for them to come back to work as a result of seeking settlements?
Yeah, we run into a lot of this, and again, it comes down to the discussion that's going on with the individual. Do they want to live this way? Is this satisfactory? So we really have to get down to it. It's very time-consuming, very labor-intensive, this population, and that's why it's difficult to have programs that are just around communities. You need a lot of people dedicated to this and a lot of money to help people get through it. So that the entitlement piece is very much an issue, and without discussion to find out where they're headed with this. Are they happy being at home doing very little and just getting the paycheck? So we've confronted this. There's no easy answer. We don't succeed all the time, as even noted in our research, that if you can get up to 20-25% in this population as they get longer away from the injury, you're doing well. But usually you don't have that entitlement piece as strongly if you're in the first 3 months post-injury, and you're able to get at these individuals, get them back to work early on. So it's a really concerted effort that everyone has to be working towards the same point, and sometimes you have to drag the family doctor into it by a verbal conversation.
And then someone else was asking if there's a similar program in BC to yours in Ontario, if you're aware of anything.
I'm not sure about that. Actually, you guys, Tanya and Dave White may know that. Do you know, Tanya?
I don't right off the top of my head, but I can definitely look into it.
Okay, thank you.
Yeah. Okay, I think that's most of the questions. There's a few more smaller ones, but we are over time, so I think I'll go ahead and wrap up. Thank you very much for your presentation.
You're very welcome.
That was very good. I'm very pleased to have had you on today.
You're very welcome.